On this Sunday evening. My name is Ahmed Osman. I'm internal medicine consultant who works in Sheikh Khalifa Medical City. It is my great pleasure and honor to introduce two of my colleagues who are really distinguished speakers. They are actually experts in their respective medical field and who have dedicated their career in advancing patient care research, and also they're very prominent figures in medical education. They're very well in the region and probably don't need introduction, but I will try to give a brief biography of them. The first speaker today is Dr. Tariq Muhammad Bakri, who is a senior internal medicine consultant who worked in Sheikh Khalifa Medical City, Abu Dhabi. He is also a core teaching faculty and clinical competency committee member. He is also internal medicine resident program faculty member. Our second speaker for the session today will be Dr. Bahar Al-Khamsi, who also is a senior consultant physician and program director for internal medicine residency at Sheikh Shakhbout Medical City. Both of them has kindly joined us today to discuss an important topic in relation to the early detection and intervention in chronic kidney disease for optimal outcome. And this is the first wave of our Emirat Society of Internal Medicine educational activity. This activity is kindly sponsored by Bayer Pharmaceutical. We will do two sessions. The first one will be presented by Dr. Tariq Bakri, and this will be followed by another presentation from Dr. Bahar Al-Khamsi, and there will be a session of questions and answers. Please send your questions, comments as the session goes, and also participate actively in the discussion. Dr. Tariq Bakri, the floor is yours.
Good evening. Thank you, Dr. Ahmed, for the nice introduction. Thank you for the Emirate Internal Medicine Society to invite us to share our knowledge and experience with the rest of the attendee on Sunday evening. So the topic is really something we see in our daily practice. I guarantee that if you're doing inpatient or outpatient, you're going to see such patient multiple times every day. So, and you know, the program is called Time to Action. Most likely, maybe you heard the same presentation or similar presentation before, but unfortunately, still it's not applied in our practice, and that's really affecting our patient care. So basically, we know that diabetes is very prevalent worldwide, especially in the Gulf area, with metabolic syndrome and also other cardiovascular risk. So you can see CKD affects roughly 2 in 5 patients of diabetes. So imagine the number. In 2019, worldwide, there were 160 million, and this number is keep going up. So as I mentioned, you're going to see it in your practice every single day. So I use this patient. Actually, this patient I encountered almost like 2 years ago, and most likely one of the first patient or second patient I recommended and started phenylalanine on. So this patient, I was consulted by the daughter of this patient, who's a physician, 66-year-old male, very concerned about her mother worsening renal function and asking if there is something else to be done. Patient is doing well clinically, no significant symptoms, no signs and symptoms of heart failure. She's diabetic with hypertension for 6 years. She's already established CKD patient, and she had osteoarthritis and irritable bowel syndrome. Very strong history for diabetes, hypertension, and CAD, coronary artery disease, sedentary lifestyle, no smoking. If you can notice her medication, she's on prindopril amlodipine, 10 milligram prendipril, 5 milligram amlodipine daily. She's also on dapagliflozin with metformin XR, 5,000, 2,000 BID. She's on statin and aspirin. And you can see her eGFR over the last couple of years is dropping slowly. Those the number the daughter shared with me. So it was 84 and it's dropping to 58. So the question from the patient and the family, is there any other treatment option to stop or reduce her CKD progression? And that's really the topic of today's seminar or symposium. We have to talk about the importance of renal and cardiovascular protection in patients with type 2 diabetes. We might not be able to prevent the complication, but at least we can delay and slow the progression for CKD. And you will see in the two presentations the importance of doing this also to prevent cardiovascular disease. So I have a couple of few poll questions. So while I'm reading the question, you will get and try to please be interactive and answer those questions. So the first one, patient with type 2 diabetes and CKD like our patient, late detection and intervention means what of the following? More cardiovascular deaths, more all-cause mortality, less heart failure cases, greater risk for hospitalization of heart failure, less MI causes, all, or 1, 2, and 4. So I will give you 5 to 10 seconds to put your answer, and then we will see the majority, how did they answer. So basically, we're trying to see if we don't do anything for such patient early, what's the complication? Next. But hopefully, all of you answer 1, 2, and 4, and we will talk about it in the next few slides. So the answer is 7. So basically, as we said, we need to identify a problem so we can find a solution. The problem that diabetic patient will develop CKD, and when they have CKD because of diabetes, it's the worst poor outcome out of any other cause of CKD. So you can see on the left side, comparing with diabetic kidney disease to non-diabetic, you can see the progression of CKD to end renal disease is much worse in diabetic patient. And on the right side, you can see the all-cause mortality and cardiovascular mortality increase significantly. For cardiovascular mortality, you can see if you have CKD and type 2 diabetes, comparing with diabetes alone, we have 3-fold higher risk of mortality and even about 2-fold more than CKD alone. So it's very bad when we have the two combination on one patient. Plus, most of our patients will have also hypertension and other problems like dyslipidemia and so on. And the problem start really not late, start early. So you can see here, if we look at GFR and albuminuria, the albuminuria, whenever it's above 10 milligram per gram, the cardiovascular deaths start going and definitely will keep going above 30. So usually when we classify, as you will see, A1, it's usually up to 30, but within those group, above 10 milligram per gram, the cardiovascular risk increase. And so same for GFR, the minute start going less than 75, the risk start getting much worse. So that's the reason, we need to do early intervention, because you can see if whenever we start either for preserve GFR with albuminuria, or if the patient has CKD, if we start early, we can save the patient's kidney, and we can delay the heart failure, the hemodialysis and transplantation, and that's improve quality of life, of course, and also reduce healthcare expenditure. So as you see here, what we talked about is very important to keep the patient to the left side, where lower albuminuria, and to save the GFR preserved as much as possible, because later on the deterioration is going to be much faster, and sometimes it's too late for us to intervene. That's the reason all the guidelines recommend us to check albuminuria, ACR, and eGFR, at least for diabetic patient on yearly basis, but in some cases we might do it more frequent to follow up the albuminuria and see the effect of our treatment. So we can try by doing this, identify, stage, and monitor the CKD, and also assess our early treatment and the benefit of our treatment. Unfortunately, with all the recommendation from all the guidelines, you can see here that we're still in many countries, even developed country, the screening is not done appropriate. It should be 100%. You can see in USA about 50%, in France 30%, Netherlands, and so on. So hopefully in our region we're doing much better. So it should be 100% for all the patients. And the reason, if we don't detect early and we don't intervene early, we go into the late diagnosis, where we will see more progression of the CKD, and we start getting the complication. And you can see here, late intervention, it means really more MI cases, more heart failure, more hospitalization of heart failure, more cardiovascular deaths. That's from like a medical point, but also from the health system point, we can start seeing more ER service visits, inpatient admissions, and people will develop fast to reach dialysis or transplantation. So that's the reason we have to work on multiple area. Of course, we need to increase the awareness of the patient that, you know, they have to screen and they have to really follow up. And also there are some system-wise improvement, but today we'll concentrate mostly on us, healthcare provider, as internal medicine, family practice, GP, as a primary care. I think we really need to also increase our awareness about the problem, do the early detection, and do the early intervention. There is a lot of misconceptions that some of those medications now available to prevent the deterioration, we leave it to the nephrologist, and actually it's not right. We're the gatekeeper for our patient. We deal with the diabetic patient more than anybody else, so we have to do this. And don't worry, the nephrologist, the cardiologist will be really happy if we can keep our patient not to reach them. So you can see here in the KDIGO 2024, they have this paradigm, which is very important. You can see at the bottom is the green, where the primary care physician role. So we have to really early detect and early intervene. So those patients will keep it under us, and we don't need really to send them later on, because sometimes it's already too late to send the patient. Of course, there are some characteristics where we have to refer the patient to nephrologist, like albuminuria, A3, rapid deterioration of the GFR, other etiologies, and so on. But for diabetic CKD, we can really do a good job and try to keep the patient in the lower stages of CKD. Another question, if you can answer, I think it's coming different, the answer, the question. There is some mistake in the question, so we can skip the question. I will read the question and you can try just to answer it, and we'll go from there. So which classes of medication have been introduced, now we have the right one, over the last few years, and now recommended to manage type 2 patient with CKD? RASI therapy, SGLT2, DPP4, GLP-1 receptor agonist, semaglutide injection, which is one of the GLP-1, and non-steroidal MRI, phenylalanine, all, or 1, 2, 5, and 6. If you can put your answer. And for the sake of the time, we can continue. Do we have the answers? I don't think it's coming. So again, you will see in the next few slides and Dr. Bahir's representation, the answer for this one. So basically now we have the 4 pillar of CKD and diabetes, which is RASI, SGLT2, semaglutide injection in particular, and phenylalanine. So as you see here in ADA 25 guidelines, we have to take care of the diabetes, control the glycemic management. We need to control the blood pressure. We have to use a statin, but also we have to use agent which with cardiovascular and renal benefit. And one of those 2 important one is the SGLT2 and phenylalanine. And as we mentioned, also GLP-1, the semaglutide injection. And you can see the guidelines is pushing for us to use some therapy to reduce the albuminuria up to at least 30% or more, especially when a patient has CKD with ACR above 300 milligram per gram. But even if it's lower, I think our job to really intervene early to prevent the progression. So going back to our patient, if you notice, she's already on a couple of medications to address her CKD, and this is more information about the patient. So she's overweight, blood pressure seems to be well controlled, hemoglobin A1C well controlled, potassium 4.5, LDL not too bad, but can be better. ECG and echo was unremarkable, but you can see her ACR 250 milligram per gram and GFR 58. So if we put it on the KDIGO heat map for CKD, you can see she's grade G3A A2. And at this level, we have the option of do nothing, and the patient, you can see, is going to deteriorate either by having more albuminuria and deterioration of GFR. But if we intervene at this time, hopefully we can keep her at this level or even bring her to lower risk. So the question, as you remember, from the patient and the physician daughter, do we have any other option to reduce or stop the CKD progression? So you can see here, we talked about, we have now the 4 pillar to treat diabetic CKD. This patient already on RAS inhibitor, she's already on SGLT2. So basically what we talked to the patient and the daughter, that now we have to introduce other modality like phenylalanine and semaglutide. At that time, the semaglutide indication was not there. So we talked about adding phenylalanine to help reducing the progression. And the reason, because we have really robust phase 3 clinical trials addressing such patients. You can see here we have the Fidelio DKD and we have the Figaro, looking at the whole spectrum of the CKD from early stage to stage 4. For Fidelio, you can see our patient fit in the criteria of the Fidelio, which is a little bit later stage in the CKD. Figaro is earlier stage, and the program was unique in a way. They had the primary endpoint and the secondary exchange in the 2 study because they were pre-specified pool analysis. Dr. Homsi will talk about it. So you can see here in our patient fit the criteria for this for phenylalanine, which is comparing phenylalanine 10 milligram titrating to 20 with a placebo. Again, our patient fits that one. So the characteristic was mean GFR of 44 and median ACR of 852. Most of the patient, or the majority, they were on RASI therapy according to the guideline. And the adherence was significant, and the study was up to 2.6. So you can see here, looking at the primary endpoint, time to kidney failure sustained more than 40% decrease in GFR from baseline or renal death. There was significant reduction, and with p-value of 0.001, number needed to treat after 3 years at 29, which is really a good number. The decrease in ACR was also significant. You can see here in this study, by month 4, we had about 31% reduction, which was maintained throughout the study. Looking at the secondary cardiovascular outcome, also it was significant, which is time to cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure. Again, it was a p-value 0.03. Number needed to treat after 3 years is 42. So we have positive primary and secondary. Looking at any therapy, we look at the benefit, which is there. We look at the side effects. Basically, with phenylalanine, it was similar side effects, any side effects or serious side effects, similar to placebo. A few issues usually people will ask about phenylalanine. What's the effect on the blood pressure? What's the effect of hyperkalemia? And Dr. Homsi will address those and the difference from spironolactone. But here you can see in the Fidelio study, there was no significant change in the blood pressure when used all throughout the study. Also, as we said, for potassium, there is a little bit increase in the potassium, but the maximum was 0.25 milliequivalent, and it was manageable, and it didn't really cause significant hospitalization, no fatal deaths. There was a little bit of increase in the hospitalization, but I think it's really very manageable. Basically, also, I will mention that if we really intervene early in our patient and we utilize this therapy before the CKD get worse, where the risk of hyperkalemia will increase if we go to stage 3 and 4. So that's another really motivation for us to utilize those medication like RASI, SGLT2, phenylalanine early. And if we reach a point where there is hyperkalemia, nowadays we have a solution of using potassium binder like patiromir or zirconium sodium. So it's really should not affect our decision to utilize such medication with such benefit, and we have to really reduce our clinical inertia. So this patient started on 10 milligram of phenylalanine on the top of her maximum dose of ACE, which is perindopril 10, and she was already on SGLT2. And you can see in 3 to 4 months, her albumin dropped about 38%, and her GFR slight decrease, which is the initial dip, which we see by utilizing RASI therapy, SGLT2, or phenylalanine, and nothing to worry about. The reason we started 10 milligram, this is the way we start. We look at the potassium. Her potassium was less than 4.8 because her GFR less than 60. So the start dose is 10 milligram. So that's the reason it was started as 10 milligram. So the question here, 1 month after starting the patient on phenylalanine 10 milligram, upon follow-up, her potassium after 1 month was 4.9. Her eGFR was 55. So what would you do with phenylalanine at this time? Increase to 20 milligram daily and repeat lab in 3 to 4 weeks. Keep 10 milligram daily. Stop it because of the drop in GFR. Stop it because of the rise of potassium. Not sure what to do. If you can take 5-10 seconds to answer this. And this is very important practical point, which really unfortunately lacking in our practice. So we can proceed because we're not seeing really the, so just like think about it and see what you do. So basically the answer is really increase to 20 milligram daily and repeat lab in 3 to 4 weeks. And this is a chart. Basically, after we start the patient, we will repeat. So after the start, now we depend on the potassium. We don't depend too much on the GFR unless it dropped to 15, because usually the indication to start above 25, but after that, if the GFR go down to 15, still we can use it. So now we depend on the potassium level. And because the potassium is still doing well, we should really increase 10 to 20. If the patient on 20, we leave it alone. If the patient also potassium 4.5 to 5.5, we maintain. So let's say this patient was 5, let's say, for example, it was 5.3, we will maintain 10 milligram and follow periodically. If the patient has potassium above 5.5, then we have to stop the medication and wait till the potassium go less than 4.8, or, in practice, I usually go less than 5, then restart. But meanwhile, we look for any other reason why the patient had also hyperkalemia. Another medication like NSAIDs, sulfa, or any other reason. And meanwhile, we can also address the potassium in the diet, maybe add diuretics and so on. And as we said, if we reach a point where we have to do potassium binder, it's very important to maximize the RASI therapy, the non-steroidal MRA. And the reason, as you see here in this chart, it's the reduction in the albuminuria is dose dependent. So when you go from 10 milligram to 20, you will have more reduction in albuminuria and more benefit for our patients. With this, I will finish. And as we said, the program is really called Time to Action. So hopefully, I gave you some practical information and some motivation to start early as a primary care physician to utilize all those medications for better benefit for our patient. Dr. Ahmed.
Thank you very much, Dr. Bakri, for this outstanding presentation. I will pass now on to Dr. Bahir for the second part of this educational activity. The floor is yours, Dr. Bahir.
Sure. Can you see my slides?
Yes, we can see your slides.
Okay, thank you very much, and good evening, everybody. Thank you, Dr. Bakri, for the excellent explanation. Dr. Bakri talked about the prevalence of CKD in type 2 diabetes, the importance of the real diagnosis, and how to approach the problem. I'm going to talk mainly about the pathophysiology of the CKD in type 2 diabetes, inflammation and fibrosis as a key driver for CKD progression. We all know for years that there's like 3 important risk factors which can cause progression of CKD in type 2 diabetes. The hemodynamic factor, which is like elevated blood pressure or elevated intraglomerular pressure. The metabolic factor, which is like poor glycemic control. And up to about recently, about 2 to 3 years ago, we start to recognize from the CKD studies and pathophysiology of the kidney biopsies that there is like significant inflammation and fibrosis in the kidney, which will lead to the CKD progression. And this inflammation and fibrosis is very important risk factor. It's been forgotten for years. All these three risk factors can lead to tubular interstitial damage, inflammation, glomerulosclerosis, mesangial expansion, glomerular hypertrophy, and that will lead to the fibrosis of the kidneys. And then we all know that CKD is a progressive disease. It will not stop, and it will continue from stage 1 to 2, 3, A, B, 4, 5, and in the stage renal disease, and patient will end up with dialysis or renal transplant. So what is the history of our approach to CKD? Before 1980s, nobody knows how to stop this, and there's no recommendation by any guidelines. In the mid-80s, people start to recognize that if we treat the blood pressure, if we control our patient blood pressure, that CKD progression is going to slow down. And then they published a lot of studies at that time. In the late 80s, they talk also about controlling the blood sugar. Since we discovered that controlling the blood pressure is going to help us to slow down the CKD, then they said, how about the sugar? And they found out that controlling the sugar also is good. In 1995 or 96, ACE inhibitors, they said not all the blood pressure are the same. We are the best in the market to stop or slow down the progression of CKD in type 2 diabetes. And then ARBs in 2001, they proved themselves to be also good medication to slow down the progression of CKD in type 2 diabetes. Until 2019, everybody kept silent. There's no new medication to prevent this or slow down the progression of CKD in type 2 diabetes. Till we came up with new medication for sugar, which is SGLT2 inhibitors. Dr. Tariq talked about them in 2019, 2020, 2023, 3 major studies done by the 3 common medication we use, the IMPA, DAPA, and CANA. And all of them, they show significant effect on the sugar. At the same time, they show they are very good to slow down the progression of CKD in type 2 diabetes. Then in 2020, 2021, the medication called finerenone came to the market and showed that I can control the inflammation, anti-fibrosis you guys never addressed before, and I'm ready to be there. And then GLP-1 receptor agonist came in 2024. I think the last quarter of 2024, they published the benefits. Those 3 medications, finerenone, SGLT2 inhibitors, and GLP-1 receptor agonists, they changed the landscape of CKD approach in type 2 diabetes. The major guidelines, they changed their guidelines and their recommendation after those 3 studies. So as we said before, we addressed hemodynamic problem or risk factor by using ACE or ARBs, as Dr. Tariq Bakri mentioned, thiazide-like medication or diuretics, dihydrophenydrine calcium channel blocker, and for the blood pressure, for the blood sugar, we use a GLT2 inhibitor, GLP-1 receptor agonist, metformin, and other blood pressure medication. So as we said, the forgotten one was inflammation and fibrosis. For years, we did not approach this problem. And in 2020, finerenone showed that in Fidelio study, and 2021 Figaro study showed the significant benefit of using finerenone in the CKD in type 2 diabetes to slow down. So we talk about hemodynamic risk factor, and we all know that ACE and ARBs are very good medication. For example, there is like 2 important studies I'm going to mention here, the renal study and the IDENT study. Renal study comparing placebo with losartan. And it showed there's like significant improvement in the primary endpoint. The primary endpoint was kidney damage in short. Doubling of serum creatinine, kidney failure, or renal death secondary to renal disease. And it showed there's 16% relative risk reduction. And in IDENT, they compare irbesartan with amlodipine and placebo. And again, it showed that irbesartan was very significantly better than amlodipine and placebo, and decreased the relative risk reduction in the primary endpoint with the kidney damage by 20%. But we all know for years that we put our patient on ACE or ARBs, but still the patient progressed to end-stage renal disease. It will not stop completely. Why? Because we decrease the risk only by 16 or 20%. And the rest of the patient, they still have what we call it residual risk, and they will continue to progress to end-stage renal disease. Until like 2019, 2023, those 3 SGLT2 inhibitor, when they come to the market and they prove themselves, they are very important medication, and it showed significant benefit. Look at the relative risk reduction in the primary endpoint. The primary endpoint again here is the composite of kidney damage, end-stage renal disease, or renal death. The CANA showed 30% relative risk reduction in the primary endpoint. DAPA showed 43, which is very significant, and the IMPA showed 28%. That was on the top of using the maximum tolerated dose of ACE or ARBs. So the benefit was merely secondary to SGLT2 inhibitors, not related to ACE or ARBs. And still, when we look at the graph, we still have residual risk for all these patients. And that was proven by watching the patients who were in DAPA and CANA studies for another 2.5 years after they finished the study. 10% to 11% of them, they experienced CKD progression and or cardiovascular events. So the risk factor, the risk is still there. We are not down to zero yet. So our patient, yes, they improve with SGLT2 inhibitors, they improve with ACE or ARBs, but there's more need for further treatment option for our patient to bring those risks, if we can, to the maximum lower area. And that brings us to the inflammation and fibrosis risk factor as a driver in the CKD progression. And the question is, what drives the inflammation? What causes inflammation or fibrosis, which is like lead to end-stage renal disease in type 2 diabetes? Theories showed that chronic kidney and heart diseases are associated with overactivation of MR. MR is mineralocorticoid receptors. Overactivation of these receptors increase the gene expression of pro-inflammatory and pro-fibrotic factors on the cell surfaces. And that will include or lead to increase in the inflammation and fibrosis. So the idea is to find a medication to stop this receptor from being overactivated by finding a medication to stop or block the MRs. And this is the idea about finerenone. It's just to block that receptors to prevent the inflammation and fibrosis, and that will lead to better prevention of the kidneys and the heart or protection. So finerenone, what is finerenone? Finerenone is like a novel medication with specific or unique mechanism of action. It targets and addresses inflammation and fibrosis, as we said before. We all know that in patients with hypertension, hyperlipidemia, high salt, oxidative stress is high, the ligand is there and it's elevated, like aldosterone, cortisol, even the receptors on the cells are very high, and then that will lead to overactivation of MR, and that will lead to inflammation. So if we use the finerenone to block that MR, we prevent the inflammation, we prevent the fibrosis, and that will result in lower risk of CKD progression, cardiovascular protection for our patients, even the blood pressure will be affected a little bit. But we all know that we have MRAs for years. Spironolactone, it's been like in the market for more than 50 years, maybe 100 years. Cardiologists been using it recently, especially in HFrEF patients. They like it, all the guidelines, they use spironolactone. But spironolactone is steroidal MRAs. What is the difference between finerenone and spironolactone? Finerenone is non-steroidal. So from the name, steroidal and non-steroidal, you know what is the difference. When you use steroidal medication, we all know for years that when we put our patients, especially male, on spironolactone, they suffer from sexual side effects. That's the main one: gynecomastia, erectile dysfunction, and dysmenorrhea. This is not there with finerenone. Finerenone has nothing to do with this. The other difference is that if we look at the hyperkalemia, we all know spironolactone is very good or strong, actually, potassium-sparing medication. Finerenone does not cause that high potassium. And if there's any risk of hyperkalemia, it's very manageable. You just stop the medication, the potassium go back to normal. In contrast to spironolactone, sometimes you have to admit the patient to the hospital or use more medication to bring the potassium down. There's another differences. The effect on systolic blood pressure is moderate from finerenone. It's very high on spironolactone. We all know that affects the blood pressure. There is effect on the renal electrolyte disturbance, and spironolactone is very low disturbance in the electrolytes in the case of finerenone. Inflammation and fibrosis, the main one, it's a greater reduction with finerenone comparing to spironolactone. Those are the major differences. It's very important to remember. So when you need to choose finerenone for your patient, you know what to look for. When you use spironolactone for your patient, you need to know what to look for and what side effect your patient is going to suffer from. Dr. Bakri talked about Fidelio and Figaro. Fidelity it's like combination of those two studies and analysis for those two studies. If we take a general look at those two studies and we look at the patient character, we find out that 60% or 40% of the patients who were involved in those studies, they have CKD or the GFR above 60. 33% between 25 to 45 and 25% almost between 45 to 60%. So the majority, 40%, their GFR were above 60, though if we look at the albuminuria, most of them, 67%, they have severe albuminuria, the range between 300 to 5,000. That's A3. And only 32% between 30 to 300, that's A2. And only 2%, they were in A1. So the majority of the patient, GFR more than 60 and albuminuria is there and significant albuminuria. This is very important. So the people who were in study, if we look at this CKD stages between stage 1 and stage 4. So any study, when we do any study, we look at the efficacy and the safety. If we look at the efficacy, when they review those two studies by pool analysis, they look at the cardiorenal protection and urine albumin-creatinine ratio reduction. When they look at the benefits, the Fidelio one was mainly on the kidney output, and it showed 23% relative risk reduction in the composite of kidney endpoint. And 20% of the people who were involved in this study, they were protected from going to end-stage renal disease and being on dialysis. In the Figaro study, when they look at the cardiac composite endpoint, they found 14% reduction in the cardiovascular endpoint, which is like non-fatal MI, non-fatal stroke, hospitalization for heart failure, or time to cardiovascular death. Specifically, when they look at the hospitalization for heart failure, they found their 22% relative risk reduction in need for hospitalization for heart failure. If we look at the patient character on the right side of the screen, 99.8% of the patients who were involved in this study, they are on maximum tolerated dose of ACE or ARBs. So those people are receiving the maximum standard international recommended doses of ACE or ARBs, though they got very much benefit from adding finerenone on the top of that. And just like to mention that most of the people who has heart failure in this study, they have either HFpEF or mildly reduced ejection fraction. In the efficacy, again, they look at the urine albumin-creatinine ratio, and there was 32% reduction in the urine albumin-creatinine ratio in the first 4 months, and was maintained to the end of the study. And remember, the American Diabetic Association, they want you to decrease it by 30%. So by decreasing 32% by putting your patient on finerenone, you do the job on most of the cases within 4 months. Now the question, can I add finerenone on the top of SGLT2 inhibitor? And if the answer is yes, if there's any extra benefits. They look at, in this study about those two arms. If you, in this study, they look at the people who received only finerenone, and the majority of them, they were only on finerenone, 12,000 patients. And the reduction A1C was 32%. They look at the subgroup who received also SGLT2 on the top of finerenone, or the opposite. They received finerenone on the top of SGLT2 inhibitor. The reduction A1C was 37%. So the effect is synergistic. So you can use both medication for your patient in your practice at the same time without any hesitation, and you get extra benefit from doing this. When we look at the safety profile of the study, we look at the hyperkalemia. As Dr. Tariq mentioned, there is like hyperkalemia, but the clinical impact was really minimal. If we compare the two arms, the placebo arm and the finerenone arm, there was only 0.19 millimole extra, or like higher potassium level in the arm who received finerenone. But how clinically significant is the side effects? If you look at the hyperkalemia leading to permanent discontinuation, it was 1.7% only, comparing to 0.6% placebo. So 1.1% differences. And if we look at the hyperkalemia which lead to death, remember the number of the patients were involved in this study were 13,000 patients. They were followed for 3 years, 0% of death. None of those 13,000 patients, after following them for 3 years, have any deaths secondary to hyperkalemia. So it's very safe medication also. So saying this about the RCT, now we need the real world data. And this is very important study done in the United States called Foundation Platform Data. It's include almost 16,000 patients. The purpose of this study was to look at the safety and efficacy of the medication in clinical practice. So they took patients, 16,000 almost patients who has CKD and type 2 diabetes, and they look at those people who were started on the treatments between July 2021 and August 2023. At that period, who was started on finerenone, and they follow them up to almost 2 years and 1 month. So it's observational retrospective cohort study. The primary or the key outcome was 3 things as usual, as we said. We look for safety, efficacy. For efficacy, they look at urine albumin creatinine ratio. For safety, they look at the hyperkalemia or evidence of hyperkalemia. Also, they took in consideration 2 important things: the comorbidity and co-medication the patients were using during this period of study. And they look at the doctor behavior, doctor position toward the medication, how the doctor deal with medication. We'll show you the result of this study. So the comorbidities, as we said, patients with type 2 diabetes and CKD, we expect all this to be there. Hypertension, 95% of the patients involved in this study, they have hypertension. Coronary artery disease, 40%, heart failure, 23%, and so on. So the majority of the patient has like kind of type 2 diabetes complication. When they look at the CKD stages, the majority of the patient has stage 3. And when they look at the albuminuria, almost 40% A3, 40% A2, and 20% A1. They look at the medication, the co-medication patient was receiving during this study. 50% they received RASI treatment, 38% they were on SGLT2 inhibitor, 25% on GLP-1 receptor agonist, and 29% they were on insulin. And this is the doctor behavior or position toward the medication. 86% of the patients, they were started on 10 milligram at the index at the first time. And only 14% they were started on 20 milligram. And then they look at those people after 12 months, after 1 year, and they found only 70% of the people who were started on 10, they still on 10. 70% they still on 10. Only 30% they were on 20 milligram. And the 14% who were started on 20 milligram after 1 year, only 29 or 30% of them, they still on 20, and the rest either stop or on 10 milligram. And this tells us a little bit about the patient and the doctor behavior toward the medication. Remember, Dr. Tariq Bakri said it clearly that the benefit you get is dose dependent. So if you want to get the maximum protection for your patient, you need to reach the maximum tolerated dose of this medication. If you have a problem with hyperkalemia, try to use the newer potassium binder, which is very available now and it's easy to use. Do not withdraw the medication from your patient just because of hyperkalemia. It is significant benefit for your patient if you put them on this medication. Can you imagine you decrease the heart failure or you decrease end-stage renal disease and ending to dialysis by 20% just by putting this medication for your patient? So try, please, if you have hyperkalemia, to deal with the hyperkalemia, first of all, review the medication, make sure patient is not taking any medication can cause hyperkalemia, review the patient's behavior, how his eat habits, and see if you need to use potassium binder medication. Try to keep the medication as much as you can and try to maximize the medication as soon as you can to the maximum dose to have the maximum protection. That from the efficacy things. So urine albumin creatinine ratio in this study, in fountain study, showed the same, almost very close, even like better than the RCT. We have 39% relative risk reduction in the 4 months from A1C, and that was maintained and even better after 12 months. The reduction was 41%. This is practical. This is what we see in our practice. This is like what the medication did in the real world for our patient. And remember, American Diabetic Association, they recommend 30% reduction. So if you put your patient on this for 1 year, you get very good reduction and you get the recommendation of the American Diabetic Association. So how about the safety? Clinical practice, definitely there's like cases of hyperkalemia, but it was very mild. 1.3% of the people who were involved in the study, remember they were 16,000 patients, only 210 patients, they have hyperkalemia. And those patients, only 0.4%, 7 patients only, they have hyperkalemia associated with hospitalization. You need to hospitalize the patient for this. And as Dr. Tariq Bakri mentioned, the risk factor for hyperkalemia, before you start fenrinon for your patient, remember the risk factor, if you are dealing with somebody with advanced CKD, like stage 4 or 4 or 5, hyperkalemia to start with, patient on beta blocker, those people are more prone to have hyperkalemia. So remember this. And all these like studies, the Fountain study and the Fidelio-Figaro study made major or drastic changes in the international guidelines, the major guidelines, American Association of Clinical Endocrinology, KDIGO, American Diabetes Association, European Society of Heart Failure, all of them, they recommend ACE, SGLT2 inhibitor, GLP-1 receptor, and nowadays they are talking about non-steroidal mineral receptors antagonists, specifically fenrinon with specific indication. It is there, and it's part of the pillar, the 4 pillar Dr. Bakri is talking about. If we look at the European Society of Cardiology in 2023, when they talk about CKD, they said after you evaluate your patient, you confirm the diagnosis, you start your treatment, and remember, fenrinon is there to treat patients with type 2 diabetes and CKD to prevent or reduce cardiovascular and kidney failure risk. Again, the European Society of Cardiology in 2023 focused update, they are using SGLT2 inhibitor and fenrinon specifically to reduce the risk of heart failure and cardiovascular death. And remember, so far the indication for HFpEF and mildly reduced ejection fraction. There is ongoing study for the HFpEF. We'll talk about it later. And this is the KDIGO in 2022. Dr. Bakri talked about it very nicely. Fenrinon is still there, and it's recommended. The recommendation level 2, grade A, is very high on the recommendation. This is the heat map. Dr. Bakri also talked about it. This is very important, and it is adopted. It is like done by KDIGO, and it is adopted by American Diabetic Association. This is to tell you how to evaluate your patient GFR, grade 1, 2, 3A, 3B, 3, 4, or 5, how to evaluate your patient microalbuminuria, A1, A2, or 3, when to refer the patient to the nephrologist, and what to do and how frequently you need to test your patient for microalbuminuria and GFR. So you need to know this heat map very well. So for the future, what's going on? Ongoing and published studies, there is like a program called PhenoFate program. PhenoFate program is a program to test the efficacy and safety of fenrinon in patients across all spectrum of kidney disease and heart failure. It has 2 big sub arms, Thunderbolt and Moonraker. The Thunderbolt program, it encompasses clinical trials in patients with CKD specifically. And one of them, which is published and indicated, Fidelity, we just talked about. There's like 2 coming at the end of this year in Q4. It's Confidence, which is the study done on combination therapy of fenrinon and SGLT2 inhibitor and the effect on the CKD in type 2 diabetes, and the fine one is like CKD in type 1 diabetes. And there's another like 3 ongoing, one in non-diabetic CKD, one in pediatric cases, and one on diabetic retinopathy. The other arm of
Dr.
the
Bahir, if you don't
program
mind,
is
wrap
the
up.
Moonbreaker trial. It included 15,000 patients specifically for heart failure across all spectrum of clinical setting. The one it's published already, but there's no like indication yet. Waiting for the indication is patient with heart failure, with ejection fraction above 40. There's one important one you need to know is finality heart failure, patient with heart failure with reduced ejection fraction. This is what we look for, and that will include all heart failure cases in this case. Thank you very much, and sorry if I took more than 25 minutes.
No, thank you very much, Dr. Bahir, and thank you very much, Dr. Bakri, for this very comprehensive lectures about cardiorenal protection. There are many questions, and I think for the sake of time, I just have to maybe sort of summarize them to include the most important issues. The first question is actually to Dr. Bakri, and that actually going around the question as to when you start the medication and the potassium increase, what should actually be the most practical steps you should do? Should you discontinue the medication and restart it again? Should you introduce one of those potassium chelating drugs? And the other question also, what is actually the role of the GB in initiating this medication? And at what stage they should be actually be proactive in starting such medication to actually to get the maximum benefit from the renal protection effect? The question also to Dr. Bahir about the inertia, how to overcome actually initiating these drugs in real world, having shown all this evidence.
So regarding the potassium, as I showed in the case, and I showed you the table, basically to start with, we depend on both the GFR and the potassium. In the study, it was less than 4.8, but in reality, honestly, because the benefit of those medication and what we're seeing in practice, the hyperkalemia is not a major issue, something to keep eye on, but it's not to prevent us of utilizing such medication. So in my practice, actually, anything around 5, I will still start the medication. But I mean, in the label or in the study, it was 4.8. But as we said, we have to utilize the medication. Then we will follow up. It's not like, we're going to start. And that depend also on the stage of where we're starting. If we're starting in the early stage, which is recommended, and it needs to be done by the primary care physician. So those medication, mistakenly, some of the primary care or GP or family practice, they believe that this is medication needs to be given only by nephrologists. I completely disagree. This is a medication we have to utilize early. On the top of the maximum dose of RASI therapy, we can introduce SGLT2, we can introduce phenylalanine. So, some people, they might be afraid to use SGLT2, then you can use phenylalanine, or the opposite. Or at the end, multiple meta-analysis actually showed that when you have multiple medications, especially as Dr. Bahir said, addressing different drivers for the CKD, then it's very important, because now we have 4 pillars. Are we going to be able to put all of them? Sometimes yes, sometimes not. So we have to really choose what's the best for that patient and addressing different mechanism. So as we said, the potassium needs to be followed, but not to be afraid of, because I think we have to look for other reasons for the hyperkalemia. And if we reach a point where we need to stop the medication, then no. I think we have now a new potassium binder to keep the maximum dose of RASI therapy and phenylalanine, because the benefit is huge. And the other part, as we said, primary care physician should really act. This is we said like time for action for primary care physician. It's a safe medication, easy to use. I only just the patient is the doctor is aware of it, aware of the benefit. Just they need to get off this inertia. And Dr. Hamsi will talk about how can we do that.
Okay, thank you, Dr. Tariq. I cannot agree more than this with you. Yes, it's our job as a primary care physician. We know the result of the study. The patient is he put his ثقة as like a trust in us, right? So we have to give him the best medication. But if you ask me, if you start the patient on medication, Finerenone, do you want to start the patient on this medication? Look at the patient profile first. Always look at the patient profile. Look at the patient history of hyperkalemia. If he has recurrent hyperkalemia, I'm very much sure if you put him on Finerenone, he will get to hyperkalemia. Maybe here will be a good idea to put him on potassium binder medication and start the Finerenone. If you are afraid from hyperkalemia, treat the hyperkalemia. Do not stop using the Finerenone for your patient, because the prices your patient is going to pay is chronic kidney disease and dialysis and maybe renal transplant. So this is the inertia we need to get rid of. Do not be afraid from the medication. The medication in RCT and in clinical practice in foundation showed it's very safe medication. There is no death from hyperkalemia. So put your patient on Finerenone. Either you put potassium binder before you start, if you're afraid, if he has history of hyperkalemia, episode of hyperkalemia before, or you put him on the medication and you observe the potassium very frequently and use the medication, potassium binder medication as when you need it. But if you have a case when potassium is above 5.5, definitely you got to stop the medication. You got to stop the medication, bring the potassium back down to less than 5, and then restart in a smart way by adding medication as needed.
And
but
can I
it's
add
very important. Do not be afraid to start to use the medication. It's very important medication. Every patient with CKD type 2, he has to be on this medication.
I will just add one thing. I will add one thing about the hyperkalemia. We should remember that most of all those patients were starting Finerenone. They are already supposed to be on the maximum dose of RASI. So the hyperkalemia is not only coming from Finerenone. So just we need to be aware of that. Thank you.
Yeah, as we said, the risk factor for hyperkalemia, just remember this: the RASI on board, advanced CKD, advanced albuminuria, and the patient on beta blocker. Those are very risk for your patient. So if his patient has those, I'm expecting him to get hyperkalemia. So maybe it's wise to start potassium binder medication with it.
So Dr. Hamsi, you have another question here. Once you have used up to 20 milligram as per the EGFR, and that unfortunately you were not able to achieve the 30% decrease in the UACR despite being on the maximum dose. This question about should you be look for other causes, cause to the deterioration of the renal function, and what is your comment on this?
Yes, of course. One of the recommendations or the things we learned from heat map is when to refer the patient to the nephrologist or subspecialty. Yes, we have cases, we put on maximum doses of ACE or ARBs, SGLT2 inhibitor, we put them on Finerenone, but it's still going worse. In this case, you need to refer to the subspecialties, and I'm not sure what else they can do, because that's so far the maximum treatment we have to slow down the progression of CKD. How about you, Dr. Tariq? Any suggestion?
Actually, I mean, exactly. And the other issue in 2025 ADA, there is a specific slide in particular to address this point, where they will ask us, although we believe that maybe the albuminuria and the CKD because of diabetes, but we should not really forget that it could be something else. There is actually a slide with like a few points to be sure about. And also, as we said, if we have all those three pillars, which is mostly used, we can always add the GLP-1. But again, we have to be sure there is no other cause for the CKD or albuminuria.
Yeah, full study, actually, ultrasound maybe, and like full study for your patient, why he's, and taking good history from the patient, ask him about herper medication he might be using. We get a lot of surprises. People, they like to use Fagah, and we saw a lot of cases like causing renal failure and hepatic failure from FIGA, eating too much FIGA. So we need to know the history, good history from a patient, good physical examination, do
I think this is one of the
ultrasound,
question asked by one of the audience, Dr. Asati. She's asking that in managing patients with type 2 diabetes and chronic kidney disease, how do commonly used herbal mixes, herbal teas, and dietary supplement often shared among families via WhatsApp and social media can impact on the treatment strategy, particularly when using agents like finerenone? And what are the practical steps to use to identify and safely intervene in these culturally embedded practices without compromising the doctor-patient relationship? Unfortunately, this is going to be an important aspect, and I think we need a different session to discuss it. But
I'll leave
what
it to
you say,
Dr.
Dr. Bahar?
Bakri. He's expert in
Okay, Dr.
herbs.
Bakri, can you take that, please? The sake of time.
Actually, again, it comes to the physician and the relationship and the way we deliver the message. We have always to explain to the patient, like, herbal medication sometimes could really be more worse than, so I think we have to tell them this is the scientific part, and this is where it's improving. There is multiple study, and nowadays we have multiple points. Again, I think it needs, just like the way we presented and like education, basically.
Yeah, the
Okay.
patient I saw, like I told him, like before you eat too much FIGA, your kidney function test was good, potassium was controlled. Now, after you ate this and you get some herbs from India, the kidney function test deteriorated. So there's like clinical evidence that what you're doing is harming you. So please stop and let's observe and see what's going on. So that's like part of the discussion with the patient, like what new things you did in your life and modification, which caused your kidney function test to get worse. Dehydration in summertime is very important also to remember.
Okay, another question here from Dr. Ahmed Fahjan. He's asking, is there too much difference between aldactone and finerenone and the cost effectiveness? I think some of this has already been covered in the discussion, but can you talk quickly about the cost effectiveness?
Yeah, the
Few words,
five
we
things
looked at
the differences we mentioned. First of all, the fibrosis and inflammation, finerenone is stronger than spironolactone. For the side effect, as like sexual side effects, finerenone has nothing to do with because it's non-steroidal medication. Gynecomastia, erectile dysfunction, dysmenorrhea is very common in spironolactone. Effect on blood pressure is a little bit on finerenone, stronger on spironolactone. Effect on the electrolytes in measure, it's mild in finerenone, moderate to severe in spironolactone. And I think the last one is the hyperkalemia, which is we spend good time talking about the difference between hyperkalemia and spironolactone is very common, is potassium sparing medication. So most of the time, if you have hyperkalemia, you have to stop the medication and treat the patient actively. In finerenone case, you just stop the medication, nothing else you need to do in majority of the cases.
Okay, I think we're really short of time, but last question for Dr. Bakri. In the Fine Arts heart failure trial, which has recently published for patients with preserved ejection fraction, obviously this trial was a very positive trial. How you feel this is going to impact on practice? Because heart failure with preserved ejection fraction or mind reduced is quite common.
So I think to start with, there was really, even like in phase 1 and 2, there were a lot of trial showing a signal for the utilization of finerenone in HFrEF and HFpEF. That's like, before phase 3. In phase 3, in the pool fidelity, it showed really reduction of the first time to reach heart failure, hospitalization to heart failure, which already addressed in the guidelines by the European Society. So now with this study was not only in diabetic, so it was also diabetic and non-diabetic. So, and as you said, nowadays with HFpEF, unfortunately, our option of treatment, SGLT2 is the best one, and the other is the evidence is little bit less. So having another medication showing the benefit we're seeing, I think it's going to be a huge benefit for the HF patients. Meanwhile, when I do the round with the resident or when I see patients, that will give me another motivation. If I have a patient who might have HFpEF and they are diabetic, why not to and CKD? So that's another way to push us to use it. So it's going to be huge. I think the molecular, with all the study is going, I think it's going to be a really huge molecule in multiple ways.
Thank you very much, Dr. Tariq. I mean, there are many questions. I don't think we'll be able to fit them all, but there is a question about, is there any algorithm for using the 4 pillars of medication, or is it based on patient profile? I think that's quite an important question, but I think most of this has been addressed during the talk. Dr. Bahir?
Yeah, the question is like not to should I give the patient 4 medication or not? The answer is yes. The question is, should I start the same time those medication or not? This is the big dilemma always. So the patient profile is very important to remember, review, and yes, ASRs should be there all the time. SGLT2 inhibitors should be there. And you need to put in mind that within 1 month or 2, you put the phenylalanine on board. And if you have problem with the potassium, you add potassium binder and SGLT receptor agonist injection, as Dr. Bakri mentioned, is very important to be on board as needed also.
Okay, by this we will reach the end of this very useful session, and I would like to thank Dr. Tariq Bakri, Dr. Bahir Husni, and our sponsor, as well as the ICON team, for this very educational activity. And I hope to see you in the next wave of the ESIM. Thank you very much, and good evening.
And thank you for you, Dr.
Bye.
Ahmed Yusuf, also. And
Yeah,
thank you
thank
for everybody in the audience. Thanks. Good evening.
Bye-bye. Good evening.